This video will discuss the major abnormalities of the standard biochemical profiles. The contents of this topic composes of blood urea nitrogen, creatinine, albumin, globulin, alanine aminotransferase, alkaline phosphate, blood glucose, serum sodium concentration, serum potassium concentration, and lastly serum calcium concentration, which will be discussed the increase, decrease, or hypo of these contents. Number 1. The blood urea nitrogen, or also known as the BUN. Urea is produced by the liver from the nitrogenous precursor, namely as the amino acid and the ammonia. Decrease in BUN level is defined as less than 10 mg per deciliter. Pathophysiology. Decrease in production is most commonly with a chronic hepatic dysfunction or long-term consumption of severely restricted protein diets. Increased urea excretion causing low BUN is often observed in animals with significant polyuria. Increased in BUN level, defined as 30 mg per deciliter, also known as azoothermia, can be caused by increased urea production in the liver, intestinal tract, or both, or by decreased urea excretion by the kidney, which is most common to happen. Pre-renal, which is decreased renal blood flow, renal, which is increased failure, or post-renal, which Number 2. The creatinine. Creatinine is formed largely in the muscle. The upper range are formed generally considered to be from 1 to 2 mg per deciliter. Pathophysiology can result from either decreased production due to reduced muscle mass or increased loss from polyuric state, but there is no clinical significance reported. Increase in level of creatinine. Pathophysiology is due to increase in production and in decrease in excretion. Increase in production is constantly and proportional to the lean muscle mass, while excretion depends on the glomerular filtration as for the BUN. Treatment for both BUN and creatinine are fluid therapy and peritoneal dialysis. In fluid therapy, you can both use Ringer solution or osmotic diuresis. Number 3. The albumin. Hypoalbuminemia, or less than 2.5 grams per deciliter. Its pathophysiology is decrease in production, increase in losses, sequestration, and dilution. During decreased production, we have hepatic insufficiency, starvation, and sepsis. During increase in loss, we have secondary hypoglycemia, hemorrhage, and GIT and glomerular losses. During sequestration, we have inflammation and fluid accumulation and dilution due to fluid therapy. Treatments are diuretics, plasma transfusion, and antihistamines. Hyperalbuminemia, or concentration greater than 3.8 grams per deciliter. The only known cause is dehydration, so the appropriate treatment is fluid therapy. Number 4. The globulins. Most of the globulins are synthesized in plasma cells and lymphocytes. Major functions such as act as an antibodies in humoral immune response and to bind compounds such as hormones. Hypoglobulinemia is defined as concentration less than 2.0 gram per deciliter. Its pathophysiology is decrease in production, increase its losses, and dilution. Treatment is seldom done with concentrated solution used. Hyperglobulinemia or greater than 3.8 grams deciliter serum concentrations. Its pathophysiology is increase in production or decrease in hydration. During increase in production, usually the result of chronic antigen stimulation such as chronic inflammatory condition, either infection or non-infections, or plastic disorder associated with tissue necrosis. Number 5. The serum alanine aminotransferase or the SALT. It is located in the cytosol of hepatocytes and released whenever there is hepatocellular membrane injury or hepatic necrosis. Decrease in SALT has no clinical significance. Increased in SALT. Its pathophysiology is increase in cellular release and production. Number 6. The alkaline phosphate. The total SAP activity is composed of the action of all the isoenzymes of alkaline phosphate. The tissue and cell known to produce the isoenzyme includes osteoblast, hepatocyte, biliary epithelial cell, intestine, placenta, and some neoplasms. Decrease in SAP has no clinical significance. Increase in SAP, its pathophysiology is increase in production, namely the drug-induced cholecystitis, neoplasia, and increase in osteoblastic activity. Number 7. The blood glucose is a net result of glucose production and utilization in the body. Cells are food intake exogenously and in glycogenesis and gluconeogenesis endogenously. Hypoglycemia is decrease in blood glucose below than 70 mg per deciliter. Its pathophysiology is decrease in production and increase in utilization. During decreased production, we have also the decrease in intake and decrease in glyconeolysis and gluconeogenesis. Hyperglycemia is increase or above 120 mg per deciliter concentration. Its pathophysiology malformed during fear and strengthening in blood collection, also increase in glucose production and decrease in glucose utilization. Number 8. The serum sodium concentration. Sodium salts are the primary responsible for osmolality and major determinants of extracellular fluid volume and distribution of the water between extra and intracellular fluid. Hyponatremia is decrease in serum concentration below 141 milliequivalent per liter. Its pathophysiology is decrease in intake, increased excretion, and overhydration. Decreased intake cannot cause alone hyponatremia. Hypernatremia is the serum concentration above 155 milliequivalent per liter. Its pathophysiology is increased intake, decreased water consumption, and increased water lost. Number 9. The serum potassium concentration. Hypokalemia or decrease in serum concentration below 3.6 milliequivalent per liter. Its pathophysiology is decrease in body potassium and distribution problems. Common signs are anorexia, vomiting, and diarrhea, which may lead to severe cases including muscle weakness, ileus, polydipsia, and polyuria. Treatment when replacement solution should not be exceed from 0.5 milliequivalent per kilogram per hour. Orally, we can give the potassium glucuride tablet or gluconate for liquid solution or subcutaneously polyuric or isotonic fluids. Hyperkalemia is increase in serum concentration above 5.6 milliequivalent per liter. Its pathophysiology is due to increased intake and decreased excretion due to obstruction or tear, decreased delivery, acidosis, damage, Addison's disease, and spirolactone. Number 10. The serum calcium concentration. Hypocalcemia is below 9 mg per deciliter. Its pathophysiology is decrease in protein-bound products, renal failure, pancreatitis, ethylene glycol poisoning. Its clinical signs are muscle tremor, panting, restlessness, sensory abnormalities. Treatment: IV administration of calcium gluconate. Hypercalcemia is serum concentration above 12 milliequivalent per deciliter. Its pathophysiology includes pseudohyperparathyroidism, renal failure, hypoadrenocorticism, immobilization. Its clinical signs includes depression, vomiting, anorexia, constipation, and arrhythmias. Treatments composed of 3 promote diuresis, glucocorticoids, and mitramycin.
Hey, that's pretty good.